Oh, hello there. Welcome to Pulmonary Embolism, a 12-lead adventure. I'll be hosting you through this. My name is Robert. If you need to pause the video at any time to review the slides, please do so. Take this at your own pace. So here is our 12-lead objectives for this content. Clinical significance of pulmonary embolism. Over 100,000 deaths can be attributed to PE each year. There's a large number of these deaths that result from diagnostic uncertainty as well as error rather than therapeutic failure. In fact, studies have shown that once medical therapy has been initiated, that mortality is significantly lessened. PE remains underdiagnosed even with all of the advancements in diagnostic technology today. So if there's anything that we can utilize to try to aid in our differentials, we should really take as much of an advantage of that as possible. Now, the 12 lead is not sensitive or specific for PE. However, it does give us insight and clues as to what is actually going on to kind of aid in our differential. So the most common signs are rales, tachycardia, and tachypnea, with another common one being pleuritic chest pain. Yes, that annoying chest pain where they just take a deep breath in and it just intensifies. Yeah, it turns out it's not always musculoskeletal. Who knew? Syncope and sudden hypotension should also pop off to you on this list, as they are both suggestive of a massive embolism. PEs are often complications of surgery, postpartum, as well as pregnancy, sepsis, and long bone fractures as well. Now you may be asking yourself, why do we see those ECG changes? That's a great question. If we look at it this way, PEs cause pulmonary hypertension, right? Which can alter the ECG appearance. We'll also see tachycardias as a result of anxiety, pain, hypoxia. We'll see dilation of the right atrium and right ventricular enlargement, which will also cause some dilation features as well. Both heart chambers dilating and enlarging will cause a right axis shift, which will be present, and we will also see evidence of right ventricular strain or ischemia as a result. This will present with ST segment changes as well as T-wave inversions. So to summarize, we'll see things like sinus tachycardia, other atrial tachyarrhythmias such as AFib, A-flutter. We'll have complete or incomplete right bundles, right ventricular strains, axis deviations, right atrial enlargement, right ventricular enlargement. So do keep that in mind, and always remember the changes will not always be seen in the presence of PE. You must rely on your best clinical judgment. Right bundle branch block, when it is present with a PE, is associated with a high mortality rate. To view the criteria, we must have a QRS greater than 0.120. Leads 1 and V6 must have slurring up of the S-wave. V1 can have different or varying presentations, and then we have an incomplete right bundle, which is all of the above with a narrow complex. Which brings us to our next causative agent, which is acute pulmonary hypertension, which will also be responsible for the ECG changes that we will come to know and love. Acute pulmonary hypertension results from pulmonary hypoxic vasoconstriction. This is a response to hypoxia. The pulmonary vasoconstriction causes an increase in overall resistance as the diameter of the vessel decreases in size. So if output is to be maintained, then flow resistance must be compensated for by an increase in pressure to the pulmonary vessels. The right side of the heart must accommodate this, so we end up seeing things like right ventricular and right atrial enlargement, which ends up turning into dilation and strain patterns. Now, I know that's really hard to visualize just based off words, but we have a few practice examples and a few examples of this coming up to kind of help you visualize and reinforce what we're talking about here. Right ventricular strain pattern will present as T-wave inversion in V1 through V3 with or without that ST depression, as you can see. It can also include the inferior leads, with the most common lead being lead 3, as it's the most rightward facing lead. There will also be a dominant R-wave presentation in lead V1. In the upcoming 12 lead, I'd like you guys to try to take a stab at finding these patterns. So let's look at V1 through V3, even into V4. What do you guys notice? Then try to train your eyes to go straight to lead 3. All right, so we have a tachycardic patient presenting with these T-wave inversions. So for right atrial enlargement, which is most commonly caused by pulmonary hypertension, we have peak P waves with increased amplitude. As you can see, the amplitude is greater than 2.5 millimeters in 2-3 AVF. My favorite misconception is that classic finding of S1Q3T3. It's actually seen in less than 20% of patients with a PE. It presents with a dominant S wave in lead 1, which gives us our right axis, that Q wave in lead 3, and the inversion of T wave in lead 3 as well. This is actually seen in many pulmonary diseases, but it is still a possible clue. Here's a 12 lead example of that pattern. As you can see, we have that S1 very deep in lead 1. That gives us that right axis. We have that Q3 being pathological in lead 3, as well as an inversion of that T wave in lead 3 as well. So imagine we find ourselves with a 40-year-old patient complaining of chest pain, shortness of breath, dizziness. They had a syncopal episode prior to our arrival, and they're also presenting with rales bilaterally. That can be a sign of an MI with cardiogenic shock. It can be a sign of a pulmonary embolism as well. All right, we need to have a high index of suspicion for both. So this 12 lead can act as a tool to help us kind of point us towards the proper diagnosis and proper treatment. So they found that simultaneous T wave inversion in the inferior leads, as well as in precordial leads V1 through V4, have the highest specificity for PE. They've also noted that inverted T waves in lead 3, as well as in V1, are only present in 1% of patients with an ACS syndrome, compared to 88% of patients with an acute PE. All right. Sinus tachycardia isn't typically present with a STEMI. All right. It is more common and the most common rhythm found with APE. So that should also kind of aid in our diagnosis. So we have a few practice examples to go through to just kind of reinforce the lesson. If you need to pause the video, feel free to. So we have the most common finding, which is that sinus tach, right? We have the T wave inversion in lead 3, as well as T wave inversions in V1 through V4 as well. Let's look at this next one. What do you see? We have wide complexes. We have that right axis, that S1 right. Do we have that Q3 lead 3? Looks like it. We have T wave inversion in lead 3 as well. What else do you see? Notice the slurring of the S wave in lead 1 and V6 with that RSR pattern up in V1. What is that characteristic of? And there it is. We have our right bundle branch block pattern. So to summarize, we have the sinus tachycardia, right bundle branch block, right axis deviation, and T wave inversion in lead 3 and V1. In our third example, let's look at this. Is it fast? Is it slow? What's the underlying rhythm? What do the T waves look like? Are there any inversions? If so, where? Are the QRS complexes wide? Is there a block? Is it right, left? What does that mean in the context of our patient? So what findings were there? Do we have any supporting signs? Well, we had T wave inversions in V1 through V3, as well as lead 3. We had a right bundle and a sinus tachycardia. So let's look at this fourth example. What we notice about the rate. Are there any T wave inversions? How wide are the QRS complexes? Where are our T wave inversions? Do we have it in lead 3 and V1? Is there any ST elevation? Is there a right axis deviation? Is it normal axis? Are there any supporting signs? So what we found was the sinus tachycardia, right axis deviation. We have that S1Q3T3, right? And T wave inversions in V1 through V4, as well as in the inferior leads. Here is our fifth example. Is there anything that pops off to y'all? What exactly do you see? we have a right axis deviation brought to you by S1Q3T3. We have a right bundle, as well as two-wave inversion and lead 3, V1 through V4. Please remember to use the 12 lead in the context of your patient's presentation and your patient's complaint. PEs are often secondary complications, so remember that when we're going out to these patients. I want to thank you guys for listening, and remember to keep PE high up in your differential process. Thank you.